Good afternoon and welcome to our Women's and Infants lecture series. During this interactive presentation, you will have the ability to ask questions via the chat box on your screen. Please post your questions directly to the moderator. This afternoon, I have the distinct pleasure of introducing Dr. Jorge E. Perez. His presentation will be on the Center for Women's and Infants, state-of-the-art care, and advances in research. Dr. Perez specializes in neonatology and pediatrics at Baptist Health, South Florida. He is the medical director of the South Miami Hospital Neonatal Intensive Care Unit and Neonatal Transport Team, and serves as the chairman of the hospital's Center for Women's and Infants. Dr. Perez is board certified in neonatology and pediatric medicine. He received his medical degree from La Universidad Central del Este in San Pedro de Macorís, Dominican Republic. He then completed a residency in pediatrics at Rush Presbyterian St. Luke's Medical Center in Chicago, Illinois, followed by a fellowship at Tampa General Hospital in Tampa, Florida. In addition to his affiliation with Baptist Health, he serves as the medical director of Kids Medical Services of Coral Gables. He is an assistant professor of clinical biomedical science at the Florida Atlantic University Charles E. Schmidt College of Medicine and clinical assistant professor at the Florida International University Herbert Wertheim College of Medicine. Dr. Perez is a member of the American Academy of Pediatrics and American Medical Association, and throughout his over 25 years of experience has held multiple leadership positions in various hospitals. Please, let's give a warm welcome to Dr. Perez. Doctor? It seems like we lost the doctor. We are having technical difficulties, and we will get him
coming
on
back
board
now.
as soon as possible. Hi, Dr. Perez.
Good afternoon, everybody. Thank you, Dr. Rivas, for the warm introduction. I want to thank Baptist Health International for setting up this virtual conference, hopefully one of many more. I'd like to take this moment to thank everybody for their attendance and for having the privilege of being part of this new quarterly video conference series. And today's conference will be discussing our Center for Women and Infants, which is part of Baptist Health at South Miami Hospital. But thank you. This is a quick picture of, for those that have not been to South Miami Hospital, this is our hospital, South Miami. This is a hospital near and dear to many of us, as I've been practicing neonatology at South Miami for approximately 30 years. And today's discussion will be talking about our Center for Women and Infants and the state of art and care and the advances on research that we've been able to do here at South Miami Hospital. Just a quick thing, part of our mission basically is for our medical services to be of the highest quality, not only of the highest quality to be innovative, state-of-the-art, preventive, and specialty care, which will be always provided, compassionately and dedicated by healthcare professionals. I think our commitment will be to set new evidence-based standards in healthcare and to support healthcare professionals worldwide by creating and implementing leading-edge best practices. And our vision will be for South Miami Hospital Center for Women and Infants to be the premier medical destination that services not only safe, effective, and efficient as well. A little brief summary on South Miami Hospital, which is part of Baptist Health. Our hospital consists of about 436 licensed beds. The things that we'll be discussing today, which is our NICU, our average daily census in our neonatal intensive care unit at South Miami Hospital is approximately 14 days. In fiscal year 2019, we had approximately 4,000 deliveries. In 2019, we had almost 15,000 NICU days. And we have a total number of about 1,500 physicians that encompasses our medical staff at South Miami Hospital. When we went down this journey years ago, we decided to develop a comprehensive care model And as you can see in the bubbles, we have this comprehensive care model in 6 different bubbles. One of them would be obstetrics, which happens to have reproductive medicine, fertility, maternal fetal medicine, which is our fetal maternal special care unit, our OB, L&D, mother baby, and our cord blood program, which is a publicly cord blood bank. We also have our neonatal intensive care unit, which also encompasses our child developmental center, where we have our level 2 and level 3 NICU, our neonatal transport team, and our child developmental center. In gynecology, we have GYN surgery, robotic surgery, gynecological oncology, fibroid center, and urogynecology. And then in our breast care, we have breast surgery, radiation oncology, breast reconstruction. And in our women's healthy lifestyle, we have behavioral and collaborative, wellness, nutrition and diet, medical wellness, surgical weight loss, bariatrics, cosmetic surgery and medicine. And in diagnostics, we have our digital mammography, our PET and CT scanners, MRI, fetal MRI, ultrasound, X-ray, and bone density as well. So this is what our care model encompasses. And most importantly, something that we found, which was incredibly important to our care model, was our patient navigator, the numbers there, which is an integral part in keeping all these circles well connected. Just a brief summary of what we've seen over the past 6 years. As you can see, we kind of peaked at 2014 where we had almost 4,700 deliveries. And as time has gone on, we're doing approximately 4,000 deliveries. And of those 4,000 total deliveries, we have about 413 deliveries that are anywhere between 24 and 36 and 6-7 weeks. So as you can see, it is no different than anywhere else around the country, around the world, that approximately about 10 or 12% of all our deliveries are preterm. This is what our nursing and our physician staff is comprised of. We have a medical director of our maternal fetal special care unit. We have a chief of OB/GYN department. We have a private practice obstetrical and gynecological services. We have private practice maternal fetal medicine specialists. We have an OB hospice group. We have a neonatology group with advanced practice providers, anesthesiologists that are also trained in pediatrics as well. And we have nursing, which are registered nurses, clinical nurse educators, and our ancillary support staff as well. Our maternal fetal special care unit, which is one of pretty much not any other unit in all of Florida, has our own maternal fetal special care unit. This is a specialized unit on the same floor as our labor floor, but only deals with high-risk pregnancies. So this center is what we call our maternal fetal special care unit. It's first of its kind in South Florida. It provides best practice care for expectant mothers and their unborn infants, and it's managed and run by our maternal fetal medicine program. Here we care for high-risk mothers with a variety of conditions, such as hypertensive disorders, diabetes, and preterm labor. And our medical team is led by a maternal fetal specialist and is collaborative, effort committed to excellence. This maternal fetal special care unit, as you can see over the last 6 years or so, has gone up in numbers. You can see that in 2013, we had approximately 1,500 admissions into our maternal fetal special care unit. And even despite that, our deliveries in the United States and around the world is down by about 2% globally. You can see that despite that, we have had this year in 2019, our admissions into our maternal fetal special care unit is almost 1,900 admissions in 2019. In our maternal fetal special care unit, we've broken it down to patient days as well. And you can see that the total amount of patient days for 2019 has gone up from even 13, which is the next highest one there. Most importantly, you can see that our patient days for patients that met our criteria, and met our criteria means that we have a preterm labor program at South Miami Hospital, and that preterm labor is any baby that's under 34 weeks. And as you can see by the purple bar, we have had 444 patient days on those patients that met our criteria for a preterm labor criteria, which is any child under 34 weeks. And our average length of stay for this fiscal year has been 3 days. In our obstetrical department, we have 14 labor and delivery rooms. We have 7 private maternal fetal special care rooms. We have 4 obstetrical operating rooms. We have 5 pre-op suite beds, 6 PACU beds, 4 OB-ED beds. And this is something that a few years ago we developed our own OB-ED, where patients that are pregnant would be actually taken to the labor floor and evaluated by obstetricians versus your normal emergency room. And then we have 48 private mother and baby rooms as well. We are an OB regional program. We were South Florida's first public umbilical cord blood banking, and we opened that up in 2009, excuse me. We also had the first maternal fetal special care unit in South Florida open in July of 2009. We are also a regional transfer center for maternal fetal special care, where we transfer a lot of our high-risk mothers. And as we all know, the best incubator and the best transport media for a mother, for any child is the actual mother, where we do transfer babies as well, but obviously the best time to transfer is when we're able to transfer the mom as opposed to the baby. And then we also participate in the Florida Perinatal Quality Collaborative, which is a collaborative in the state of Florida that is actually a collaboration between multiple hospitals in the state, where we work on protocols and guidelines on how best to manage not only obstetrical but neonatal care in our state as well. Our obstetrical nurses are, as you can see, very certified. 64% of all our L&D RNs are certified in the National Certification Corporation, not only in EFM tracing, but also in lactation as well. And we have 70 of our mother-baby RNs, which are 60% certified as well. At South Miami Hospital, we've been very privileged and honored to be recognized for many distinctions. We've been recognized by the U.S. News and World Report in 2018 and 2019 as the best hospital ranking. We're also one of the Fortune 100 best companies to work for. The Joint Commission Gold Seal of Preterm Labor and Prematurity, and that's something that we'll go over on a different slide, but that's one that we're incredibly proud of, and one that not many hospitals around the nation actually are part of or have been certified for. We're actually certified in Leapfrog for patient safety, HealthStream for excellence awards, best place to give birth, elimination of elective deliveries prior to 39 weeks without a medical indication, best companies for working mothers, outstanding patient experience, Kids Crown Awards. We've been a magnet nursing hospital since 2004 and a champion of quality in 2020. And there you can see some of the logos of the companies that we're associated with and been recognized by. For our NICU and our Child Developmental Center, we have NICU patient days. So far year to date in 2020, we have almost 14,000. Our transfers in, because we're a major neonatal transfer center, are 186 transfers in. We've done 44 NICU surgical cases, and we've also had almost 16,500 child developmental visits, and this is even despite COVID. This is something that I was mentioning to you earlier. This is something that we're incredibly proud of. So we've been certified by the Joint Commission in preterm labor and in prematurity for now, this is our 3rd cycle with no findings for either one, preterm labor and or prematurity. We're the 3rd in the country to be recognized in preterm labor and the 5th in the nation, and the only one in the state of Florida to be recognized for both prematurity and preterm labor. So that's something that we're incredibly proud of. these are the NICU patient days by year. So we're almost at, back in 2019 and 2018, where it's approximately 14,000 NICU patient days. Our NICU admissions are 842 so far year to date. And we usually run around 1,000 NICU admissions per year. So it's a pretty robust program, probably one of the larger ones in our state. In the South Miami Hospital, in our NICU, we're incredibly proud to have many firsts. So we're the first basically in the state of Florida to have 24/7 neonatology in-house coverage, and that was over 30 years ago. We were the first also to have a community-based air and ground neonatal transport team, the first to have high-frequency ventilation, not only an oscillator, but a jet ventilation, the first to have volume ventilation. So as you know, in what we do, it's incredibly important to manage these kids from a respiratory point of view. We were the first also to have total body cooling for the treatment of hypoxic ischemic encephalopathy. First, as we mentioned earlier, to implement a delayed cord clamping as well as publicly cord blood banking. We were the first also to train neonatal nurse practitioners and physician assistants in the neonatal intensive care unit world. We've had multiple university affiliations and written agreements, not only to train students, residents, but also our allied health professionals as well. We were also one of 4 centers across the state of Florida to implement newborn hearing screening in the state of Florida. And we did that back in 1999. And that was following a pilot study where we convinced the state of Florida and its legislators that it was more common to have a hearing deficit than what is to have a metabolic disorder. We're the first community hospital to have inhaled nitric oxide. We're also the first NICU in Miami-Dade County to have a camera for each NICU bed where virtually, and this is even the pro-COVID era, not only parents, but grandparents, but significant others, immediate family members can look at the child 24/7 through their own NICU camera, not only locally, but all over the world as well. And then we were also the first hospital in South Florida to implement a post-discharge telemedicine virtual encounter. And that was really incredibly important during our COVID times when we recognized that our pediatric offices and even our subspecialists were closed because of COVID. And that was a way of doing this smooth transition from the in-hospital environment to the outpatient world, where these parents didn't feel that they were left abandoned and no one else to turn to. So we implemented our virtual telemedicine, where we go and discuss, how is it, how has been the transition towards the home environment, making sure they were taking their medications, making sure that they didn't have anything that they had any concern of, because over time, if you've done this long enough, you realize that the babies have been in the intensive care unit so long that the parents are only concerned about what day you're going to be discharging them, and no matter how much time you spend educating them on medications, on follow-up visits, it sometimes goes in one ear and comes right out the other because all they want to do is go home. So it's actually worked out incredibly well to have this virtual encounter using what we have now in telemedicine. Another thing that we've done over the years is that we've become very research dependent. Over time, we've participated in multiple studies, and these are just some of the few that we've participated in the last 12 months. We've participated with them in very prestigious universities and organizations, and you can see them there. Some of the IRB studies that have been approved so far this year at Baptist Health or at South Miami Hospital are colostrum. It's a study basically for oral care using colostrum. Our PNET study, which is a high-dose epigen and how it affects neurodevelopmental outcomes, and that was published in in a very prestigious New England Journal of Medicine article. We also participated in our FN3 study, which is the Florida Neurological Neonatal Network which is collecting data for patients basically that are hypoxic ischemic encephalopathy during our hypothermia protocol, where we cool babies for 3 days to avoid neurological sequelae. We participated in Aerofax studies, which is just different ways of, infusing or instilling surfactants, where you don't have to intubate somebody to give somebody surfactant. You can actually do it via aerosolize. We are participating in a FAST registry, which is for fetal arrhythmias, where we're developing at South Miami Hospital our fetal arrhythmia center as well, where we treat the mom, obviously to treat the baby, where we correct the baby's arrhythmias before they develop hydrops fetalis or other comorbidities associated with having a fetal arrhythmia. We're doing a Medtronics study using a different type of pulse oximetry, not only a different mode of pulse oximetry, but also a very least or a more sensitive probe in order to avoid any trauma to the extremity of a child, because as we know, their skins are so friable. We did an infrasur study, also the same thing, basically using instilled or aerosolized surfactant, thereby avoiding intubations. We have multiple pulmonary hypertension studies using sildenafil as one mode of treatment. We've done multiple NEC prevention studies or necrotizing enterocolitis prevention studies, including the use of probiotics. And we're involved in a COVID-19 viral study where we're collecting data on patients basically that are born with COVID-19 as well. And then we have also multiple potential studies. The one that's very intriguing to us is not only our Silo 2, which is also our sildenafil study, but also our neonatal seizure study. So using different neonatal seizure medications in order to have better outcomes as well. So these are some of our last publications. These are all done either in 2019 or at the end of they're either in 2020 or at the end of 2019. And I mentioned to you the aerosolized surfactant studies in infants with RDS. And that was a study that actually showed that administering aerosolized surfactant was as good and prevented basically patients from being intubated. And as we know, intubating a child is a very traumatic experience and one that we shouldn't take lightly. So over the years, we've gone to become a lot less aggressive on intubations, whether putting them on nasal CPAP or now even using aerosolized surfactant to avoid an intubation and mechanical ventilation, because as we all know, the longer someone is intubated on a mechanical ventilator, the longer or the higher incidence of bronchial pulmonary dysplasia or chronic lung disease. The one that we did for the New England Journal of Medicine was a randomized trial of erythropoietin for neuroprotection in preterm infants. So this is a study using high-dose Epigen, and this is something that we've used over many years, where we were trying to see if it had some neuroprotective effect. So that was a very good study, and from that study, we've also seen that by using high-dose Epigen, less chances of hypotension, basically, and blood transfusions as well, post-delivery. Also, we also looked at acute kidney injury using high Epigen as well, and diminished the incidence of AKI. We did multiple studies on PDA, and for the neonatologists in the group, this is something that we've always been something we've gone back and forth what to do with a PDA in an asymptomatic child, whether we should treat it like in the old days, including surgical ligation, or we should just let it be. And that's a study that we've looked at the differences in basically in treatment, not only in areas or in institutions, but even across groups of doctors. And then we also did basically the effectiveness of different drugs, either using indomethacin or Tylenol or ibuprofen, basically, or Tylenol or acetaminophen in the treatment of a PDA. And the last one is the same thing, as basically just how do we make sure that we standardize how people treat PDAs. At South Miami Hospital, something else that we did years ago is that, like every other major institution, we were involved in an ethics committee Years ago, in 2014, we decided that we were going to separate ourselves and have our own perinatal ethics committee, because the things that we discuss at our perinatal ethics committee aren't things that we discuss usually in an adult-run ethics committee. At the time, we united our NICU and our labor room, so where we now go over all the ethical dilemmas that we have either in our NICU or in our labor room, and where we have representation. As I'm the chairman, we have Dr. Bendito basically as the co-chairman. He's our chairman of labor, of our OB chairman. We have our director of NICU, which is Christina Mess, our director of maternal child, which is Susan Chandler, and Elizabeth Pereira, our nurse manager. And it's a multidisciplinary team with over 20 members, where not only do we look at what's best for the patient, but also we look at what's best for the family. And some of the things that we've implemented was to obviously everybody get to know these parents before they come in delivery, because a lot of them come in with lethal congenital anomalies that are incompatible with life. And for many years, we're admitting these babies into our neonatal intensive care unit. And at the same time, A, it's an expense, and two, it's a separation. And the last thing you want to do is separate a child with a known lethal congenital anomaly from their parents, where the child's last breaths are with strangers versus with their parents. So what we've done is that we've developed a mechanism that the child has a different colored chart. Everybody knows from environmental to food services that, you know, they know when they walk into the door basically that it's not like congratulations on the birth of your child. They know this is something, is a huge issue, a huge dilemma. And when they come in, they don't have to repeat the same story to 20 different people. So we found that to be very instrumental in what we do to try to see how we can not only be cognizant of people's privacy, but also be respectful of what we say and what we don't say when we walk in someone's room. We also have developed multiple programs, and this is some of the things that we've developed over the years, and we evaluate through our P.I. measures. We developed a golden hour bundle. We also have done patient satisfaction and perceptions of care, kangaroo care, breastfeeding, mortality, retinopathy of prematurity or ROP, stage 3 and 4, severe intraventricular hemorrhage, grades 3 and 4, chronic lung disease, which is one of our latest PI projects, including NEC, sepsis, and necrotizing enterocolitis, stage 2 and 3. So we're really focusing in on chronic lung disease. How do we make sure that we reduce the incidence of chronic lung disease? And I think a lot of it's going to do with this less aggressive way of ventilator management or intubation, aerosolized surfactants. Try to come up with criteria to get these kids extubated as soon as possible. As we all know, the longer you're intubated and the longer you're on oxygen, at least high concentrations of oxygen of more than 40%, basically the higher chance you are going to have a chronic lung disease and all the comorbidities that go with the chronic lung disease as well. And the necrotizing enterocolitis. So what we've done is that we've not only encouraged breast milk, and probably about over 75% of our patients are actually expressing their breast milk. And then we developed a donor breast milk program. So now we're close to 100% of our babies are on either donor or expressed breast milk. And at the same time, we've identified that feeding comes into 3 different categories. One is when you start the feeding. So we've developed policies and protocols in place on initiation of feeds within the first 24 hours of life, because at a minimum, that's called trophic feeding or gut priming feedings that has all kinds of beneficial effects if you started early, especially when it comes to the brush borders on the intestinal mucosa, and they're able to tolerate it much better. So that's stage 1. The second stage is when do we supplement or we add human milk fortification to either our donor breast milk or our expressed breast milk. And we're starting to see that the earlier is better. And we're trying to do it at about 80 cc's per kilo per day. A lot of times we used to wait until almost they were on full feeds before we started to supplement. And we all know over the years, breast is great, but it also lacks a lot of nutrients as well. So we try to supplement those nutrients by adding human milk fortifier. And then the last stage of feedings is when do we get them on full feeds? And what we consider to be full feeds is about 150 cc's per kilo per day. So in a 24-hour period, they should be receiving anywhere between 150 and 160 cc's per kilo per day of either a 22 or 24 cal, either formula or breastfeeding, in order to accomplish at least 20 grams per kilo per day of weight gain. So that's our ultimate goal. A little quick synopsis of our NICU. A lot of people can't believe that our neonatal intensive care unit is a 62-bed NICU. Sometimes I tell our adult colleagues that we have more NICU beds than probably the whole health system has in adult beds at one institution. So we have 62-bed NICUs. Of those, years ago, we developed private and semi-private level 3 rooms. We have 24 private level 2 rooms. We have 23 ward style level 2 units, or level 2 beds, which that's the old ward style, which is just an open ward that are separated by curtains. Our private rooms are separated by actual walls and doors. In our group, at South Miami Hospital alone, we have 31 board certified neonatologists, 27 neonatal nurse practitioners, 7 physician assistants, and 1 clinical nurse educator. And we have 113 registered nurses. 45 are certified in high-risk neonatal, 4 are certified lactation consultants, and 1 is certified in advanced lactation. And we have 15 clinical partners. And we're part of the National Certification Corporation and the lactation consultant certified as well. In our NICU regional programs, as one of our slides depicted, last year we had 218 transports. We had almost 23,000 visits in our Child Developmental Center. And that's a great thing to have at South Miami Hospital and within our Baptist Health family, is that a lot of places have neonatal intensive care units, but not very many places have a Child Developmental Center where 100% of our patients will be seen, whereby we can do a great job saving these babies' lives, but when they go home, they get lost and they're not able to achieve the best outcome possible. So the Child Developmental Center not only makes sure that they're meeting and exceeding their milestones and their expectations, but they're also educating our parents as well on the different things that they should be looking for and the different things that they can be doing at home to make sure that every child gets the best opportunity and choice possible. We also have a regional program for whole body cooling, and that's for our HIE babies or our hypoxic ischemic encephalopathy babies. Our criteria for cooling is anybody that's greater than 36 weeks, although we've done less than 36, depending on the circumstances, as long as the parents are aware. There's not enough literature out there to support that. But we've seen that even in mild cases of encephalopathy, and mild we consider to be after we score them using the SARNAT scoring system, that for many years we were only doing the severe or the moderate, but now we're actually doing the very mild as well, because we've seen over time that cooling somebody at a temperature of 33.5 degrees really has very minimal side effects, versus if you wait for somebody to have a seizure and then start cooling, and especially after 6 hours of age, the chances of whole body cooling having any impact or any positive effect goes out the window. So we're actually very proactive in deciding when we're going to actually utilize our whole body cooling. We also have an inhaled nitric oxide regional program as well. Not only do we do it at our health facility, but we also do it in transport as well. We do have a breast pump rental station that for many years, a lot of our parents weren't able to bring in. And I think that's why we have such a high success rate in our breast pumping. It's about 85% of our admissions into our neonatal intensive care unit. Basically, the parents insist on breast pumping, and by having this rental station, basically it makes it easier when they go home. And then we also belong to the Southeast Florida Association of Neonatal Nurses, which is CFAN. And like I mentioned before, we are a part of the Florida Perinatal Quality Collaborative Committee, that we not only share best practices, but we look at best practices with other hospitals within our state. And not only do we share within our state, but we share outside of our state as well. Also, years ago, we developed what we call our P.I.C.A program, and this is prenatally identified patients with congenital anomalies. So we work in collaboration with our maternal medicine partners, where we would meet with these parents, presumably right after they meet with the MFM physician, where not only do we bring them and show them a tour of our neonatal intensive care unit and show them what's going to be like, because the last thing you want to do is come in emergently and starting to meet people. So we get the right people to be there to show them, but we also talk about the plan of care before they come in and they deliver, as opposed to either after or while they're under the effects of anesthesia. So we come up with a plan of care prior to the delivery. We get to meet the parents prior to the delivery. We get to look at their records prior to delivery, where hopefully we can not only give the best care possible, but also utilize the parents and educate the parents as much as we can on what we can expect when the baby is admitted and delivered. And that's part of our team, which is our prenatally identified congenital anomaly team. These are some of the things that we've done over the years, and this was done many years ago. We went live, I think it was in 2018. And these are some of our NICU cameras. As you can see, it's called NICView. It's a camera that all 62 beds in our neonatal intensive care unit have. It's secure, it's real time, it's password protected. So it's not something that somebody can actually come in and view your baby. It's a password that you have to give to someone in your immediate circle and your immediate family, so they can access that remotely. We have found that it's incredibly important for family bonding. As we all know, many mothers go into what we call postpartum depression, and that even happens with a full-term baby that's at home with you, because as we all know, a mother's hormone or a woman's hormone after delivery gets all out of whack. So you can imagine if you have a normal newborn at home and you become depressed, how difficult can it be if you have a preterm baby and you have to leave the hospital and you're not able to see the baby, and every time the phone rings, you're expecting a call from the hospital, and a lot of the times those phone calls are not very pleasant. So families or mothers become very depressed. So one of the things that they can do is that they can go and view their child 24/7. So it's a good way of bonding. It's a good way of identifying that that your baby is normal, as your baby is alive, and it's another good way of when you wake up at 3 or 4 o'clock in the morning to breastfeed or express your milk. It's a good way of putting on your camera and identifying all the reasons why you're actually waking up at 3 o'clock in the morning and expressing the breast milk. So this was something that was fully funded by our foundation. It was done by one of our Mercury Balls, and that's a yearly event that we have to raise funds. And as I mentioned earlier, it's 62 cameras and there's one at each bedside. And there it is. We went live in February of 2018, and I think that's been a huge success. And this is a virtual
Welcome to
tour. It's a video so you can see, and I'll just welcome you, and you can take a look at what our NICU looks like, what our mother-baby unit looks like, what our labor room looks like, and what our postpartum rooms look like as well. The only thing that we don't have here, which we're going to have, which we forgot, is our maternal fetal special care unit, which that is coming up.
South Miami Hospitals. Welcome to South Miami Hospital's Maternity Unit. We are excited to be part of this special moment in your life. This virtual tour was designed to enhance your hospital experience by showing you all of our main areas. When you arrive at the hospital, The very first step is to get checked in at the main registration security desk. After that, your stay begins and you will be directed where to go next. Obstetrics emergency is an area where a nurse and a physician will assess the amount of cervical dilation, frequency of contractions, monitor the baby's heart rate, and also contact your doctor to give an update on the urgency of your condition. If you are in active labor, a nurse will take you to your private labor, delivery, and recovery room where you can comfortably wait for your doctor to arrive. If you require a C-section, a nurse will transport you to one of our operating rooms to prepare you for surgery. After your baby arrives and you are healthy and stable, a nurse will escort you to one of our comfortable postpartum rooms where you are going to spend the rest of your stay. If you are interested in a more spacious postpartum room, please ask about our suites, which are based upon availability for an additional out-of-pocket cost. While you are resting, your newborn will be weighed, measured, and have vital signs taken. And should your baby need to be separated from you, we have a nursery. You will be reunited as soon as possible. Should your newborn need specialized care and observation, a team of physicians called neonatologists and neonatal nurses will care for your baby. The Neonatal Intensive Care Unit at South Miami Hospital is one of the largest in South Florida, with Level 2 and Level 3 units. Hospitalization for vaginal delivery is usually 48 hours and 72 hours for C-section. After that, you and your baby will be discharged. You will be ushered out in a wheelchair to your car. Don't forget the car seat. To help you feel at ease, our hospital also offers an obstetrics emergency department, 24 hours a day, 7 days a week. This concludes your virtual tour of South Miami Hospital's Maternity Department. We look forward to caring for you and your baby. Welcome to
When I found out that I was having a baby girl, I was extremely excited. My pregnancy was very, very easy up until the 6-month mark. My baby girl decided to come at just 24 weeks. My family and I was very scared, but because of her chronic state, we were transferred to South Miami Hospital.
And her hospital stay was pretty complicated. She had a long list of problems that we commonly see in babies that are born at extreme premature ages. Mainly she had what we call bronchopulmonary dysplasia or chronic lung disease of premature infants. She had other problems too, like increased pressure within her lung circulation, which we call pulmonary hypertension. She had multiple infections and other conditions too. For her chronic lung disease, she received several courses of steroids to try to help her lungs. However, she was still not ready to be able to breathe on room air. So that's why the decision was made to place a tracheostomy to help her with the breathing.
From there, she continued to strive. It helped her tremendously. She was able to breathe with this machine. She started getting stronger and better. And in March of 2020, she was able to come home.
Lori's finally leaving. Oh my.
She was able to be discharged from the NICU after 8 months of being in the hospital.
A lot of things were done to help her get home.
She was only able to come home with a ventilator. She also had a G-tube, which is a tube that allows the baby to get feeding through their tummy instead of their mouth.
They also had a full CPR class and home apnea monitor teaching. So she went home on a monitor. Mom was allowed to room in, which means that she stayed overnight with Lori in the room to be able to have hands-on experience with care, bathing, changing clothes, feeding, and all the other requirements for her to be able to be ready to go home.
So this was a special time for us, but it was also scary because coming out in March was in the middle of the pandemic. And even now, months later, we continue to wipe things down. We use masks around her when it's necessary. We don't allow too much exposure for her because of her chronic lung disease.
Families do get help after they take premature babies home.
There are follow-up calls. The case manager also follows up just to make sure you have everything you need in place to assist a kid. And all those things are set up prior to leaving the NICU.
Lori is doing amazingly well. We're very proud of her progress. She's a true success story.
Lori is doing great. She has come a very long way. Last week, she started crawling, so that was a huge milestone for us, and we are super excited about that. She's been doing a lot of tummy time, meeting with her physical therapist, doing feeding therapists as well. She's learning how to eat by mouth, and she's just doing incredible. We are so proud of her. As you can see, she's not on the ventilator during the day, and she's breathing on her own a lot more. And if I can give any parent any word of encouragement, I would tell you that it does get better. In the midst of it, it looks so discouraging, and many parents can't see past it. But I am a living testimony. My daughter is a living testimony that if you just stick with it, you can get through it.
And this is just a quick pictures of our Child Development Center. I apologize for going over my time.
Thank you, Doctor. We seem to have lost Dr. Hakeem, but we'll ad lib as we go. Thank you for an amazing presentation. And I wanted to know, it's so important. You noted that how many different support levels between nursing and all the different specialties and things like, being a magnet hospital. I mean, some folks might not be from the States and might not understand what that means. And so can you explain a little bit about the before all this and now and the big difference that changed? You've lived it all. How has that changed for you, that evolution of CWI? And then how does it help to have nursing that is at the magnet level? And can you explain a little bit about that?
Absolutely, Dr. Rivas. I mean, neonatology has come a long way. I mean, when I first started neonatology, we weren't even saving anybody under 28 weeks. And now basically our lower limits of normal are 22 weeks. So anybody over 22 weeks has a fighting chance. You know what I mean? by the Academy of Pediatrics and the NRP. Everybody's telling you 23 or 24. A lot of our parents are high-risk parents. A lot of these moms are in their 40s, basically having their child for the first time, and can possibly be their only child. You know, as we all know, the younger you are, the less chance you have of survivability. But even at 22, 23 weeks, basically in the United States and even under our hands, we have about a 60% chance of survivability. And it's not about survivability without any kind of complications. It's good survivability. It's just not, you know, it's more important nowadays. It's all about the quality of life, not the quantity of life. So because of everything that we've done over time, whether it's, you know, delayed cord clamping, basically, where you hold off on, you know, clamping somebody's cord and making sure that the baby gets enough blood flow, that they start with a higher hematocrit than normal. That has been huge. Also with the golden arrow, where we maintain the temperature, not only when the baby arrives at the NICU, but even in the operating room or in the labor room. It's so important to maintain the baby's temperature, because anything like that, any alteration and even temperature will increase or decrease your cerebral blood flow. And it can cause hypotension, intra-reticular hemorrhages. Also, nitric oxide has been a huge success. Even in our preterm babies, like Lori, as you saw, even at 23 weeks, basically, although a tracheostomy isn't all that common, as you would see with Lori, it's, you know, we probably have one tracheostomy every 5 to 10 years. But because of her chronic condition and because she came from another facility, we were already having to deal with some of the things that were done somewhere else. And that's why, you know, Lori ended up with tracheostomy. But there's so many things. Surfactant has made a huge impact. More gentle ventilation, less aggressive intubation, now aerosolized surfactant that we're using. For kids that are asphyxiated, basically this whole body cooling. I remember years ago, babies would be, you know, having, you know, an encephalopathy, seizing, and there was nothing for us to do other than stop the seizures. Now we're actually able to do something even before they develop the seizures or any long-term sequelae. So neonatal medicine over the years has advanced tremendously. You know, using, you know, the right tools, the right ventilator, either an oscillator or a jet ventilator, pulse oximetry, CO2 monitors that we don't even have to draw blood. So it's come a long way over the years. So, you know, we're proud of it.
Thank you, doctor. And if expanding a little bit, you know, you talked a little bit about COVID and everything else. How were you able to separate COVID from non-COVID in that type of arena?
Well, initially, you know, there was not enough evidence that would support anything. So we took a really hard approach that, you know, we weren't allowing a father to be in the delivery room with the mom. We wouldn't allow anybody to come visit the mom. As time went on, and as we identified that, you know, that we didn't have to be that draconian, we started opening up our deliveries. So now, as it stands today, we test everybody that's coming in. We test all the moms, so we know they're COVID positive or negative. Even if they're positive, we still allow one person to come in. We don't separate the baby and the mom any longer, because we've seen that, number one, moms can directly breastfeed, doesn't cross, you know, it doesn't cross into the breast milk. We know that if they wear a mask and if they social distance themselves, only come to close to the baby upon touch time. We have not had any cases of either it having or occurring transplacentally or after delivery. So we know that for a fact, that we haven't had any positive babies, because we test the baby before they go home. We test the mom before she comes in or before she delivers. And then via telemedicine, we follow these babies for 2 weeks after they go home. And of all these deliveries, which is almost 4,000 deliveries, of those, a certain percentage are COVID positive moms. We have not had one case convert from negative to positive. So we've really done a much better job in having that family unit, or that family bonding that initially we didn't know enough of, and we try to separate them. But now basically we pretty much have it that the dad can be there at the delivery, and the baby doesn't have to be separated from the mom, and the mom can directly breastfeed.
Doctor, the congenital anomalies that you mentioned, when you get to this high level of care that you all provide, can you explain a little bit about the different types of surgeries that you've all had to do while the baby's still in utero, and the different complications of what you're able to manage that before maybe things would have had to been sent out?
Yeah, well, we don't do much in utero other than ablations of a twin-to-twin transfusion. So we're not there yet where we're doing in utero neonatal surgery. There are places around the country, basically, whether it's for spina bifida and things like that, that are being done, or even for, if a child has hydronephrosis, is not urinating, putting in stents. But at South Miami Hospital, basically, we're not at that level other than basically ablations of twin-to-twin transfusion. Now, post delivery, we were able to handle everything other than cardiovascular surgery. So the only thing that we don't do at South Miami Hospital is cardiovascular surgery. There's not enough to go around, so we'd rather have it done at a place basically that does them often, as opposed to either siphoning or stealing patients, where all of a sudden now in Miami, there's nobody that would be proficient at it. So we prefer to transfer those patients to another institution.
Doctor, I'd like to welcome back Dr. Hakeem, who apparently was kicked out, and we let him back in. And so, Doctor, I think there's a question here for you, if you can expand on the colostrum question.
Dr. Rivas, thank you. I did not, unfortunately, my screen shut down completely, but why don't you go ahead and read the question, because I cannot see it.
Very good, thank you. So could the doctor explain a little more about the colostrum study is the question, Doctor?
Sure, yeah, the colostrum study we've done that for many years, but we're now associated with Northwestern University in Chicago, Illinois, where we're collecting data on the use of colostrum for oral care. So colostrum for oral care, because of the antibodies basically, and the immunoglobulins that mom's breast milk has, by putting it into the cheek, into the mouth, and by cleansing the mouth with colostrum, it basically enhances the production of antibodies and enhances immunoglobulins, where not only it avoids infections, because that's one way of getting into a child, either through an intubated trachea or through the mouth, but it also, because of the colostrum, because of the absorption, it also has an effect on enzymes, where now all of a sudden you're actually being able to tolerate. So not only does it have an infectious disease component to try to avoid you from having an infection, but it also works on actually tolerating feeds eventually as well.
Thank you, Dr. Perez. I want to make sure that we highlight something, Dr. Rivas, and it's the fact that thanks to Dr. Perez and his team, South Miami Hospital has become one of those centers of excellence that is not only noted in the state of Florida, but throughout the world. So thank you for all your efforts, and thank you for saving so many lives of babies in these past years. One of the things that we wanted to do today to share with our physician peers around the world is, in essence, give a welcome and a kickoff to this new lecture series for South Miami, and especially for your area, Dr. Perez, in neonatology, and highlight all the great accomplishments of South Miami, and in order for us to have discussions in the future about very intricate type disease processes that you guys deal with. If I was to ask you, Dr. Perez, one of the conditions, aside from the ones that you just mentioned, one of the conditions that you are always asked to evaluate and treat, and it's a constant resurfacing of these type of conditions, what would that be? What condition would you think that it's the one that most attention is given and referred to South Miami Hospital?
That's a very good question. I think because we're known as a regional center, I think that we get a lot of the fascinomas as well as a lot of the bread and butter things as well. So normally when they come to us, if they don't deliver with us, we get basically babies that have not, they haven't been able to diagnose it, or they haven't been able to treat at other institutions. A lot of them have been either necrotizing enterocolitis, babies that have had perforated bowels, and or chronic lung disease like Lori. So over the years, we've become extremely specialized in treating babies with any kind of intestinal situations, even as close to even almost pre-transplant when it comes from intestinal. Try to avoid an intestinal transplant. At the same time, chronic lung disease or bronchopulmonary dysplasia, which is something that is incredibly common when it comes to preterm babies and causes all kinds of complications later on in life.
Thank you. There is a question for you. It says, hello, does the hospital have experience dealing with cases of AFE?
AFE.
Could you elaborate what do you mean with AFE, Mr. Breton? In the meanwhile, Dr. Perez, the fact of the matter is that the center is one that has had that designation for quite some time. How many of those centers do we have here in the United States? Is it in the state of Florida? How many do we have? Do we know this this fact?
I'm sorry, Dr. King?
How many of these centers, similar to what we have, do we actually have in the state of Florida? Or how difficult is it to become one of those centers with the designation we have in South Miami?
Yeah, well, through our certifications, as we're the only center in the whole state of Florida that have certification, not only in preterm labor, but in prematurity as well. So we're really proud of that. That's a very difficult accomplishment. And across the nation, we're only 5 that have been certified for prematurity and only 3 for preterm labor. So that is incredibly important. That's incredibly difficult to obtain. And because of what we've been able to do over the years, and this is our 3rd cycle of being certified. So there's nothing new to us. One, a lot of people don't have the expertise to actually be certified for this. And it's a difficult hill to climb, and some others don't. So I'm very proud of being the only center in the state of Florida, so to answer your question, that is both certified in preterm labor and in prematurity.
And doctor, not only that.
Clarification is, does the hospital have experience dealing with cases of AFE, which is amniotic fluid embolism?
Yeah, so we have, and that's a very good question. Obviously, as you know, an amniotic fluid embolism is a rare but a very lethal condition. But we have had amniotic fluid embolisms in the past. Some of our patients basically have walked away from an amniotic fluid embolism, and others have not. You know what I mean? So, we know that it can occur. We deal with these cases. Other things that we deal with a lot as well is, the rare implantations of the placentas, placenta accretas, things like that are also very high risk as well.
Dr. Rivas, you had a question?
Yeah, going back to the Joint Commission accreditation, doctor, both those things, even though we're #1 in South Florida, I think there's very few, right, in the whole United States that has actually both accreditation.
We're the only one in the whole country that has both. Yeah.
Thank you, doctor. And then the next question, Dr. Hakeem, if you'd like to handle it.
Well, yes, it's actually someone that would like to talk about a neurobiologist, but we will take that offline and we will definitely address it via email with the person.
And those questions of percentage of C-sections, which is another question that's there by, thank you, Jimena Marzan, for your question. Doctor, a little bit explain about, percentages of C-section, but when you're such a high risk facility and the amount of cases that you get, the amount of C-sections might be occurring a little higher than normal because we basically are trying to get the baby from the natural incubator to the other incubator. And can you expand a little bit about how C-section helps you to be able to control the situation?
Yeah, absolutely. You're absolutely right, Dr. Rivas. We're a little higher than normal only because we're a regional center, and a lot of our patients basically that come in to us basically are very high risk. Not only is the mother very high risk, so we have 2 reasons why people transfer patients to us. One is the mother that can be extremely high risk. A mom with a congenital heart disease herself, a mom with a BMI of greater than 40, things like that. A mom with severe health syndrome or hypertension. So we get a lot of those moms that are referred to us from everywhere else. So we're not the normal delivery service that other hospitals might have, that their cesarean section rates are very low because, they normally get the 20-year-old that comes in and delivers a child for the first time. We get the 40-year-olds basically that could have been pregnant 10 times. This could be her only pregnancy, her only positive pregnancy. And on top of that, with all the comorbidities. So we're not your typical, so normally around the country is about 23%, and that's what everybody tries to strive for. We're higher than that. We're probably closer to the 40% than 23%. But because of our high-risk population and because of the clientele of patients that are referred to us, we're higher than what your normal obstetrical hospital could have or would have.
I remember we transferred a case from one of the countries, an air ambulance transfer. And since we also have a bariatric program at South Miami Hospital, it's one of the few places that can handle certain folks, 500 plus. We were able to transfer that patient, if you remember well, doctor, and we were able to help that patient. And you recall the case, I believe it was from the Bahamas that we took care of a bariatric case. And so that also leads to other C-sections and stuff like that, because you are taking even that type of an adult patient to be able to help them out.
Yeah, that's why I was talking about the BMIs. A lot of these moms, right, that come in with multiple deliveries, C-sections beforehand, nobody wants to do VBACs anymore because of the medical liability. So that's another issue. And then the Academy of Obstetrics and Gynecology, right? So they have given the mother, which rightfully so, the right to decide that she doesn't want to go through vaginal delivery, that she wants to have a cesarean section. So that's another part of the population that we are starting to see more and more, that a mom will just come in and say, I don't want to go into labor. I want to deliver on whatever, November 18th at 3 o'clock in the afternoon. I want to have a C-section.
So that has been a definite shift from the movement several years ago, where they actually were asking us to change or to helping change the culture and making sure that the woman decides to go through the path of vaginal delivery, which is this definitely brings a change. We're short of time, but we do have a question, and it has to do with child development program. And the question is, how many years do you follow kids after you enroll them in these type of programs?
Yeah, until necessary, but at a minimum of about 2 years.
And doctor, one of the beautiful things that I've seen, most beautiful things I've seen, is can you talk about also for all the other physicians that are watching, the program that you have in place that follows the patients after their discharge, and when you get all those kids together, which are sometimes adults now, and they were part of your program, can you elaborate on how you bring those families together and you welcome them back?
Yes. Yeah. So every year, thank you, Dr. Rivas. I actually had a slide on that, but I thought it was going to be way too many slides. But every year, like Dr. Rivas is mentioning, we have what we consider a reunion. It's called our NICU reunion, where we invite all the patients that we've had over the last, 25, 30 years, basically, to come back. And it's great to not only see them and see what they're at. A lot of them are professionals. A lot of them are in colleges. Others are in high school. I mean, it's just great to see them basically and reconnect with those families, because remember, for a lot of these people, the only family that they have and the only people that they understand or that understand what they're going through is either our medical staff or our nursing staff. And it's so nice to see them come back, and the smiles in their face when they see us and they thank us for everything that we've done over the years. It's what I believe makes all of us get up every morning and want to go back to work.
Well, doctor, we really appreciate you. And Dr. Hakeem, would you like to do the closing?
Of course I would. Dr. Perez, we could have you here all afternoon. We enjoy listening to you. We're actually looking forward to all those clinical lectures that you have in store for us. So on behalf of our entire team at International, I would like to thank you for accepting our invitation in such a busy day for you. If you have any additional questions to all of you, if you do have any questions for Dr. Perez, please send them to internationalbaptisthealth.net. We'll make sure to forward those questions to him to elaborate and send back. We look forward to seeing you at our next Women and Infants lecture series scheduled for February 10th, 2021. Thank you again. Be safe and have a phenomenal weekend.
Thank you, everybody. Have a great Thanksgiving, everybody.
Thank you. Likewise.
Good night.
Bye.
Thank you, Dr. Rivas.
Thank you, doctor.